CataractCoach.com. Expert management of a dense white cataract. Our guest surgeon here is Dr. Steve Safran from New Jersey. Fantastic surgeon. Always a pleasure to learn from him. Look at pre-op. Really dense. And look at the capsule. Fibrotic and wrinkled. So a very challenging case here. Once the blue dies, and you can see all that central wrinkling of the capsule, that's going to be tough to cut through. So you can see he's trying to start the capsulorhexis here, and it's really challenging. Now, if all this fibrotic area is central, you can try to go around it with the rhexis. So the peripheral part of the capsule looks relatively normal. It should tear reasonably well. That central part that's all wrinkled is going to be very leathery, very tough, very hard to get a continuous tear through. So he's getting around. He's pretty good. It's going to get a little stuck probably in this area. And so he's going to pull on it, doing almost like a little Brian Little maneuver. There it is. Bringing that in, and there. It looks pretty reasonable. Take it. More viscoelastic going inside the eye. Now, this is a tougher spot. What do you do here? You can pull on it again. Oh, you got good. Very nice. And now, but this area coming up right near the paracentesis, that's a really thick fibrotic area. So what do you do here? You pull on it. Now, you can't yank too hard because all you'll break the zonular support. He's going to use a coolant hook in his left hand to help support and provide some counter traction. He's going to try tear this. Another option is you could actually put your side port blade back through the paracentesis and use that to cut it sharply because you already have that right there on your field. Or you could use another instrument like micro scissors to go inside there and cut that last little band. And so he's going to try pull it again. And yeah, this is a tough case. And you can see the capsule centrally there, how thickened it is. Remember, normal anterior lens capsule is probably 14-ish microns or so, somewhere in that neighborhood. And this capsule looks much thicker than that, especially in that white fibrotic area. And so nice little cuts here being made with some retina micro scissors. Now keep in mind that one area that's been cut may not be as strong as the rest, so you got to be a little cautious. And let's see the technique here. So very dense nucleus. You can see that central density is pretty high. Now, Dr. Safran's a fantastic chop surgeon, so what's he doing here? Well, he's debulking the nucleus. Doing a stop and chop technique and really getting a wide central groove allows you to really debulk that nucleus. Remember, if you just chop the nucleus, you may end up with a difficulty in cracking that posterior plate unless you get the chopper on the back side of it. Remember, you want to trap the chopper on one side and the probe on the other, the nucleus trapped between the two in order to really get that crack or chop to penetrate or propagate through. So here, continuing the groove. So if you split a nucleus with this chop, remember each half is 50%, right? But here, because you're removing that central, really wide groove of tissue, each half of the nucleus is going to be less than a half. It's going to be like 40% or even 35% of the original volume. And that's going to be a lot easier to remove. So he's taking his time to groove here. Now look at that one spot there nasally is a little thinned out, and so he's going to thin out the rest of it to match. And by having less tissue there on that posterior plate, by grooving it deep enough, it's going to be easier to split the nucleus. So he's taking his time. Look how much time he's taking for that. And now to split the nucleus, notice how he's doing the splitting motion away from the area where he had to cut the capsule. And that's so that you don't push that outward force on any possible little weakness there and cause the rhexis to zip around to the back. Here's one half the nucleus coming out. Again, it's a little bit less than a half given that the central part's been debulked. And in these dense nuclei with a lot of nuclear sclerotic changes, that central part of the endonucleus is the densest, and that's already been removed pretty nicely. Also, when you're doing that groove, you're furthest away from the central corneal endothelium. So by being farthest from the central endothelium, you're a little bit safer in that regard. You can also recoat the endothelium with viscoelastic. Yep, there you go. Here's some dispersive viscoelastic to recoat the central endothelium of the cornea and protect it. And then just, look, using this Tosinski hook in the other hand to chop it. And now the nucleus can be further split, subdivided, and removed. And that comes up pretty easily. Make sure you have good fluidic settings here, so you're not going to allow that posterior capsule to come up towards the phacoprobe as the last piece is being removed. And so certainly a lot of density in this case. I'm sure he's employing some good phaco power modulations, maybe limited duty cycle, a burst or pulse mode as well, in order to decrease the total energy. And now here, time to clean up. There's not a whole lot of cortex that's left, but I like his technique here. He's just injecting and kind of doing a sweep there to help loosen up any residual lens material. And then filling the capsular bag. And that's a nice looking bag. Now, don't overfill it because you may have a weak spot. Here comes the IOL, 3-piece IOL. So you may ask, why a 3-piece lens instead of a single piece? Well, the smart move is a 3-piece because it has more options for placement, right? You could put a sulcus based, you could put the haptic sulcus optic through the rexis. If you need to down the road, if this decenters at all or gets loose, you can also suture it a lot easier when it's a 3-piece lens. And you can see he did some good capsule polishing as well. There's the Rex at the end, just about a perfect overlap. Wow, what a tough case. Thank you for sending that in, Steve. That's always a pleasure to learn from you. And what a lucky patient. Here, post-op, day 1, nice clear cornea, beautiful result, happy patient. Thanks for watching.